Hi, everyone. My name is Ishtar Govia. I am a registered clinical psychologist in Jamaica, and I am trained as a research psychologist. My training is from the United States of America. I live and work between Jamaica and the UK currently, and I do work related to dementia care improvement, particularly dementia care improvement in and for low and middle income country contexts. And I'm very passionate about care and care equity, about treatment options, about training of the workforce, particularly as is relevant for low and middle income country contexts. And why is that? Because the current and projected burden of Alzheimer's disease is disproportionately in low and middle income country contexts. When we think about what is really necessary in terms of innovation, sometimes the innovation is really very soft touch. It's very much along the lines of training opportunities, exposure opportunities, but then those also have to go hand in hand with things like appropriate compensation for services. And often our budgets in our country context, for example, our budgets from our ministries of health, they are very siloed and they are disproportionately focused on psychiatric institutions and providing that level of care. Archaic models of care, admittedly, because they're very much based on colonial models of care provision, very much based on the asylum model of care provision. But the monies that are needed to actually compensate health professionals adequately so that they want to stay in these occupations, that they want to stay providing these services, that type of resourcing is not available in the public healthcare system. And so what we find a lot, and what I've seen a lot in my care management, is people who are lost, families who are lost. They have no idea where to turn. They feel very overwhelmed because they have gotten misdiagnosed. They've been told that what they're experiencing with their loved one is just a normal part of aging. They've been told, for example, somebody who might be experiencing signs of what we may later find out through referral to the one neuropsychiatrist is a Lewy body type of dementia. They've been told that that's something related to just regular psychosis, and so they're medicated for psychosis, but they're not treated in an appropriate way that is reflective of a dementia-related process happening. And as we know, with Lewy body's dementia, medication management is really crucial because of the hallucination, because of the disruption of the sleep cycle, et cetera. So we're faced with many, many challenges in these contexts. We're faced with, and particularly in the care management consultations, we see a lot families that are very overwhelmed. We see cases of families that have been completely bankrupted. This is middle-class families that have been completely bankrupted by having to think about care provision for their family members because financially bankrupted, because they did not anticipate that there would be these needs. There is no discussion about long-term health and long-term care needs. And it's really difficult to talk in our context about the need to put in place advanced care directives, the need to think about a will. When you mention the word will in Jamaica or in many Caribbean countries, people think that you're just trying to kill them. So there really is an aversion to dealing with things related to long-term planning. And that aversion to dealing with things related to long-term planning is, you can consider them in concentric circles, because it happens at the individual level, it happens at the family level, it happens at the community level, the services level, the systems level, at the national level. And then there's the pressure from the outside pressures that are entirely objective at times, seemingly, like natural disasters and other factors that really are related to repercussions of climate, for example, that then just jostle with these concentric circles. So it's a very challenging situation that we face in the Caribbean, a very challenging situation that requires a sensitivity to these contexts in order to actually develop and implement innovations and solutions that can make a difference. And sometimes in conferences, I've heard people talk about robot technologies and sensors in bed, where you can actually tell that somebody is moving around a lot more, and these types of gradual attention to people's habits and behaviors can often produce biomarker type data. But then the challenge with these things is that they are built on an assumption that everybody's sleeping in a bed in a house with a roof, where they can use these types of technologies, that somebody can actually have a camera in their space so you can see how they're moving around in different locations. And these types of technologies are not really sensitive to some of the actual realities on the ground. So, for example, I was on one conference where someone was talking about a little mini robot that could move around the floors of a house and be able to help you identify where somebody is. How does that work in context, for example, where there is no flooring per se, where it's dirt floors? So these are some of the challenges that we face in our context, and these are some of the circumstances that really do need to be taken into consideration when we talk about innovations. But there are persons that are in high-risk group and vulnerable populations, and they're living in contexts like what we call tenement yards, where it's multiple households on one piece of land, and its households is very, very unstable infrastructures, very, very fragile walls and roofing, etc. So some of these technologies are not going to work. The technology of the thing to attach to the person so that you can see where they're walking. People don't want to do that. People don't want to be identified as, needing a special assistance, etc. So I think the solutions, the innovations, whether it's pharmacological or technological, really has to be much more sensitive to the actual populations that we're working with and where those populations are. It's really about understanding what inequity means. It means that there are some countries, there are some contexts, there are some populations that just do not have the things that you take for granted. And what that means then is that the investment must be inequitable, because the investment must be disproportionately towards those places and spaces and populations that do not have those resources in the first place. So if you really are thinking then about solutions and innovations, that they can truly be reflective of the populations that they're supposedly for. We're dealing with this even with the biorepositories, right? So our institution is one of the only ones that actually has a freezer that has capacity to store blood samples. And what does that mean then when you're thinking about things like all of the work that's requiring the use of these biomarkers that are, physiological related as well? So it's just mind-boggling. How can we talk about innovations and that they're pharmacological, but they require these RCTs that require specific infrastructure that these contexts do not have?